Aloha and welcome to the final day of the International Stroke Conference here in Honolulu, Hawaii. I'm Donna Arnett, President of the American Heart Association and the American Stroke Association.
And I'm Joe Broderick, President-elect of the Stroke Council for the American Stroke Association.
And I'm Steve Greenberg. I'm chair of this year's International Stroke Conference Program Committee.
And Steve, you guys put together an awesome program. Congratulations. So much new data coming out here. And it's just impressive how many attendees we've had and how great the response has been to the science.
Well, the conference is always exactly as good as the science that's presented, and which made it a great conference this year because so much exciting science has been presented. So it's just a pleasure to stand back and watch it unfold like that.
So terrific. So tell me a bit about the prevention studies. There were some major prevention studies this time.
Right. So several of our late-breaking trials really get at issues that come up every day in clinical practice, and they have to do with how to treat people after they've had either a lacunar infarct or a TIA or a minor stroke. So the CHANCE study that was performed in China has shown pretty strongly that a short period of dual antiplatelet therapy with both clopidogrel and aspirin lowered the risk of a stroke, especially in that early time period. So it was really just in one ethnic group. We don't know whether it will be true across all populations, but it's very exciting and it's such a common problem for us for how to prevent those very early recurrent strokes that we know are a real hotspot of danger to the patient. The other trial, the SPS-3 trial, looked at whether a lower blood pressure target would lower the risk of recurrent stroke in people who've had a lacunar stroke. And as you know, the lacunar strokes are tremendously common, that if you count all the ones that people know about, ones that people don't know about, it's probably more than any other stroke type there is. And the results are a little bit borderline. The lower blood pressure target just barely missed at the significance level, but good evidence that it may in fact lower the risk of recurrent stroke, and it did significantly lower the risk of hemorrhagic stroke in those patients. So for those of us who are clinicians, I think it's a pretty strong argument to aim for lower blood pressures in this very common situation.
Excellent. Well, I also heard that there was a lot of media interest in the Southern diet. So this was part of a large study called REGARDS, and they found that what we would expect, that you drink a lot of sweetened beverages and eat a lot of fat, you have an increased risk of stroke that was dose dependent. And the best diet is that high fruits and vegetables and fish diet. So that was good confirmation of the importance of prevention from a dietary perspective for stroke.
Right, and I think it's important to point out that despite the name Southern Diet, there's a lot of Southern Diet outside the South, so it's a lesson for everyone, but it probably does have special bearing on the stroke belt that we all know about and so much seek to help to improve.
Absolutely.
And I would say even for children. Think
Yes.
about what's in school, lunches and stuff, you know, sometimes a lot of fried food and a lot of sweetened beverages, and so I think it's a message there as well, because they have the longest life to live ahead. They can maybe decrease the risk of stroke.
So there was also some great intervention studies. Joe, why don't you tell us your highlights that
Sure.
you found
So,
most?
as people know, the approach to acute stroke has been TPA. That's the standard treatment. It's been around since 1996. We've been working on ways to try to help improve the outcome, and to do that, one of the ways of doing that is to go inside the artery, put a catheter up, and see if we can take out the clot or remove the clot in different ways. And so, this actual meeting had more data about the endovascular approach than had been previously published by about 4 or 5 times the amount. Now, unfortunately, what we found is a couple things. One is that the endovascular approach added to TPA, and this is part of what's called the IMS-3 study, that didn't improve outcomes overall. It was no problems with safety, which is great, so it's not harming people. But there was signal in patients who have the very severe strokes, and particularly patients who have big clots in the major artery, the internal carotid artery. Those patients did very poorly with IVTPA, and there was a pretty good signal that endovascular therapy was more effective. But for the other locations of clots, we have work to do. Also, that trial did not have some of the latest technology, and we're hopeful maybe with the latest technology we can maybe do better, but we're going to need some more randomized trials. The other trial was an Italian trial called the Synthesis trial, and in that trial they were comparing IVTPA to just the endovascular approach, and again they found no difference. Now, they were able to deliver the endovascular therapy very early on, And that study also didn't include some of the clot removal technology that's been more recently found. But again, it means that we have work to do. The last study, which is a smaller, smaller study to look at an approach of using brain imaging to select out patients who may have salvageable brain, and that was the MR rescue study. And what that study found was that unfortunately, in even using that brain imaging to select out patients who had clot removal didn't seem to benefit in that group who had what appeared to be salvageable brain, which means we also have to go back to the drawing board a little bit and figure out how best to manage and how to best to see what part of the brain is still salvageable. And we got to change, I think, our imaging techniques. But that's, again, we have work to do. We have some signal there, but we have, I think, other trials that are going to be coming that hopefully will be someday at this meeting.
Right, and I just add, we all want trials to be positive, but a well-performed negative trial is tremendously valuable to the field. It really, and for studies like the one Joe mentioned in particular, IMS3 was just, will act as a map for where we need to go in future studies.
Excellent. So you had a very new aspect to the program this year called the Next Big Thing. It sounds very big. So tell us about the next big thing.
Well, I think we're always looking for ways to engage our audience and also inspire people to think not just about the last trial, but the next trial, sort of where the field is going. So we had 11 very courageous speakers get up under a little bit of a game format where they had exactly 5 minutes and we would cut them off mid-sentence. We did cut off a few of our very good-natured speakers at 5 minutes. But the serious message underneath that was just what a wide range of ideas there are for where we may be going in stroke. And this really ran the gamut from areas such as worldwide prevention, the huge burden of stroke in poor countries, and also some new ways of thinking about stroke. For instance, stroke is a lifelong problem that, almost getting back to Joe's point about early dietary intervention, the idea that the risk of stroke may be set quite early in people's lives, and focusing not just on the late stage of right before you get the disease, but even at earlier stages. So it was very, very inspiring for new ideas, and I think we may try it again. It was, I think, a success with our audience. Well,
thank you. Excellent. So Joe, Steve, thank you for your work for the council and for an outstanding program this year, and congratulations.
Thank you so much, Donna.
Thanks very much, Donna.
And thank you.
Thank you.